Hi, everyone. We'll give it about a minute. Just to make sure that everyone who's coming in will be here. Great. Well, thank you everyone for joining us for today's webinar Wednesday. My name is Ashley Mueller and I'm the manager of educational programs. Today's topic is creating responsive programs to meet changing population needs, presented by Dr. Tasha Turner-Bicknell. As is with all other webinars, the chat will be open for you to be able to say hello to your fellow attendees. And if you have any questions for our host, please make sure to put those in the Q&A section at the end, and then we will answer questions at the end of the webinar. So a little bit about our presenter today. As a harm reductionist population health nurse and member of the board of directors of Harm Reduction Ohio, Tasha has a long-standing demonstrated commitment to improving access to health services for people who use drugs. She has an extensive experience in harm reduction, including syringe service programs, overdose prevention, capacity building, mobile outreach, and legislative advocacy. So with that, I'd like to turn it over to Tasha.
Thank you so much. Let's see if I'll share my screen here. Welcome everyone. Thank you so much for joining. Let's see if I can. All right. Thank you for joining. We're going to talk about having responsive programs that change to changing needs, whether those are client needs, population-based needs, but how we can create responsive programs in harm reduction. Let me see if I can move this out of the way a little bit. All right. Thank you so much for the introduction. I am Tasha Turner-Bicknell. I am a harm reduction consultant and subject matter expert. I am also Associate Professor of Nursing and Program Director for Public Health Nursing, DNP and Certificate Programs at the University of Cincinnati. I'm located in Southwest Ohio. There is no conflict of interest in the presentation of the information included here. So to talk about harm reduction programs and how we can be responsive to changes that have occurred and are continuously occurring, in the dynamic life that we're all kind of living in, the society that we're all living in. Talking at first, let's just set the table for our discussion. Let's talk a little bit about harm reduction. Harm reduction, when I started working in harm reduction in 2014, and in my community in Ohio, even though we were kind of considered Southwest Ohio, we border West Virginia and Kentucky and Indiana. We really were kind of considered the epicenter for the first wave of the opioid epidemic, which was prescription opioids. But despite that, we really didn't have a strong network of harm reduction services. So harm reduction was kind of new to us at that time. So to define harm reduction really started as a movement that was founded in social justice. It creates a set of principles to guide service delivery that's really rooted in the human rights of people who use drugs. The goal of harm reduction is to reduce the negative effects of drug use, to empower individuals to protect themselves, and we refuse to condemn or ignore drug use in our community. When we very first started talking about harm reduction, in spaces with healthcare professionals, hospital systems, health networks, health departments here in my region. At times there could be some, feelings like, oh, are you enabling people? Do you think that drug use is healthy? And I think it's important to point out that harm reduction, we're very much aware of the negative effects that come from substance use and can come from substance use. And we feel that if we, as a healthcare community and a public health community, ignore substance use, then we're kind of turning our back and not seeing something that really, needs attention, and that we want to be here for people and to provide them with the services that they need today. Harm reduction is an important part of an evidence-based public health practice. Harm reduction has been proven to be effective over and over again. It saves lives and prevents disease. So just some bullet points and quick facts about how harm reduction does save lives and prevent disease. Syringe service programs can reduce HIV by as much as 33% and hepatitis C by 21%. Overdose education and naloxone distribution can reduce overdose mortality by 40%. And we're going to talk a little bit here in a few minutes about how we're starting to see some of the impact of that work in those overdose death numbers nationwide. Fentanyl test strips can lessen substance use risk behavior by 43%. Education on safer smoking supplies and distribution can reduce risk of HIV and Hep C. And we do know that individuals who engage with syringe service programs are 5 times more likely to enter a drug treatment program than those who never engage with syringe service programs. So sometimes when people will say to me, especially when I very first started doing this work, do you talk to every client about getting them into treatment? How many people go to treatment? And I always would emphasize that, when I'm working out in the community, I want to always be working with a harm reduction framework. I want to meet the client where they are, just as they are, and offer them the services that they need today, and really let them lead me in how I can serve them. And what we know is that that does a lot of things. It builds a relationship. For some people in this population, harm reduction workers might be the only healthcare person that they interface with, or a public health person, I should say, because sometimes it might be a social worker or a peer recovery person who is working for the program. It's not always a healthcare professional per se. But we build relationships, and then what we know through the research is that over time, when that person is interested in treatment, they are more comfortable to come to us and are more likely to be successful in that treatment. So let's talk just a little bit briefly, a summary of the scope of the problem in the United States. It's estimated that 22.5 million Americans use illicit drugs. I always think that that's a low number. I think that those, when you kind of dig in a little bit on where those numbers come from, a lot of times it's from a large survey that's done every so often. And I don't know how many people are really filling out that survey and how many people are being honest. But either way, it's not just a small amount of people, it's a lot of people. Overdose deaths in the United States had soared between 2021 and 2023. In 2021, it was the highest number that we had ever seen. It was over 100,000, 106,699 souls in America lost to overdose death in 2021. And as someone who had been working in this field for quite a while when that happened, I will tell you, I was astounded by that number. I felt somewhat defeated. I thought, we are giving more naloxone out than ever. How is this happening? And it really led us to reflect on what we were doing and how our programs were potentially not meeting the people that they needed to meet, that we weren't serving all of the people that we needed to serve, and what could we do to kind of expand. And we're going to talk about that a little bit today. The numbers remained high in 2022, 107, 941,000, and then came down just slightly in 2023. Overdose deaths in the United States have surged more than 30% in 2020, which was primarily driven by synthetic opioids, so fentanyl and fentanyl analogs. Overdose deaths involving opioids have increased over 6 times since 1999. And there are significant racial disparities when you get into these numbers. For example, most of you are probably aware it's been a major news story in the last few months that overdose deaths in the United States are set to be have a significant decline. The 2024 numbers are still somewhat provisional, but it looks like the numbers are going to decline about 24%. But it's important to note that that is mostly being seen among white Americans, and we're still seeing significant racial disparities in overdose death numbers, in particularly among Black and Native American residents, and also of Latinx communities as well. And we'll talk a little bit about why that might be. I think that it's important for us to, as I mentioned, I really reflected on, how could this be that we're still seeing all of these overdose deaths? And I will share with you that when the numbers came out for my state, we looked at overdose deaths and the racial disparities associated with those deaths per zip code. And where I work and live, just one zip code community over was the community that had the highest overdose death among Black Americans in the state. And so it really had us start to really kind of question what are we doing wrong? What could we do better? How can we repair this relationship? How can we serve this community better? The impact of structural racism in the uptake of harm reduction services is significant. I think that if we look globally all around the world, I think historically oppressed populations are less likely to engage with harm reduction services for a variety of reasons. I think the criminalization of drugs exacerbates an already existing distrust of the healthcare community that has frankly been well earned here in America. Ethnic minorities are overrepresented in the US criminal justice system. Their communities are often over-policed. People may be hesitant to engage in harm reduction services if they fear prosecution or if they have a distrust of the public health establishment and or the police. Black Americans die from overdose at the highest rate in 2021. It's an increase in 44%, up to 44%. So what we see with that is when we look at the opioid epidemic broadly, it has 3 phases. Or waves, sometimes it's referred to as waves in the literature. The first wave being prescription opioids, the second wave being heroin, and then the third wave being fentanyl. And we really see in 2021 that spike, the increase in overdose deaths among Black Americans with that fentanyl, that third wave of fentanyl. Black, Indigenous, and people of color can be less likely to be engaged in naloxone distribution. And I think that it can be for a variety of reasons, some of which we just talked about, and some of that fear of prosecution. I think that programs need to really think about how they're targeting communities in need and what strategies need to be applied. For example, if all of our programs are very syringe centric, if I call my program a syringe service program, and maybe I have a syringe on the van and we're driving into a community, well, people who don't use syringes might not think that I have anything for them. What is going to cue them into that they need to carry naloxone if they don't use a syringe? So with the increase in illicit fentanyl, we have seen that now fentanyl is in everything, right? It's in pressed pills, it's in cocaine, it's in powder and crack cocaine, it's also in methadone. So a lot of people who are maybe smoking their drugs or snorting their drugs, who may have not considered themselves to be at risk for overdose death during the heroin wave of the opioid epidemic, they are at high risk in many communities now because of drug adulteration. So I think that, really kind of thinking about how you're engaging the community, also reflecting on that we as a public health workforce and as a harm reduction workforce, that we reflect the community we serve. And I think for most of us, we know that there's a lot of work to be done there. We've seen a lot of improvement in the diversity of the workforce, but it could certainly be better. I think that opportunities like community coalitions and community workforces that look to partner with community leaders, such as, I mean, I have great colleagues and allies in the faith-based community. We have people who go into beauty shops and barber shops and community restaurants and food pantries, places where we want people to know that if they want to be a part of the harm reduction movement, that they're included. And we want them to be able to distribute naloxone if they want to. And we can also provide them training if they themselves want to go into the community. So programs such as that really leverage the leaders that exist in the community, and also get you really in touch with the people who need naloxone, people who use drugs in those communities, and the people who spend time with them, can be really great. I think additionally, minority communities are often exposed to a highly variable and unpredictable illicit drug supply. I think that what I'm really talking about there is drug adulteration, which we were just talking a little bit about that when we talk about illicit fentanyl being in substances like cocaine and meth. Uh, but I think that the illicit drug market is always changing, right? And that's the nature of an unregulated market. When I was doing this work in 2017, it was something called carfentanil in my region, which was a veterinary tranquilizer. And it was extremely potent, and people were at very high risk of overdose death if they were exposed to it. And then, we kind of realized that was happening, and there was kind of a crackdown, or we start to look and see, how is the market, how is that getting into the market? How can we restrict the availability of that? And then the market kind of moves on to something else. We see things like nitazines. We see things like xylazine, which is another veterinary tranquilizer, which was highly present in the illicit drug market in my region, just up until recently, and is still around. But that unpredictable nature of that market can be, some scholars and some research evidence suggests, can be even more highly unpredictable and variable in minority communities. I want to share this with you, not so much for the specifics, but for more just as an example. So this is in my state, in Ohio. This is overdose death by drug type. And you see here, the black mark, the black line is heroin, the red line is meth, and the blue line is cocaine. So this is overdose deaths by drug type over about 10 years. And I think the real takeaway from this is talking about having responsive programs. We need to know, and if we're doing harm reduction work, we need to know what's out there. What is in the drug supply. We need to be looking at information from coroner's reports. We need to be talking, cross-sectoral conversations with emergency room staff and physicians, public health professionals, the coroner's office, drug seizure data. All of these things can kind of come together to really inform our work and help us provide more effective programs. So for example, if you look at heroin, if I'm out in the community talking about heroin today, like I was in 2015, people would be looking at me like, what's this lady talking about? Like, nobody's using heroin. We really don't have heroin in the area anymore. So it's important to know that. And also it changes my messaging, right? Like, now that I know that fentanyl is in pressed pills, powder cocaine, crack cocaine, and meth, then that helps with the public health messaging. We can let make the public aware of the kind of risk that is out there, so that they can protect themselves and do things to mitigate that risk. And you see meth here really rising and remaining high, and is still very popular. And something that we see quite a bit of is meth, of course, with fentanyl. So, what are some examples of some responsive programs and how we can be adaptable in our harm reduction programming? Safer smoking kits is a great example. When I initially started this work, we did not give out smoking kits. We didn't really talk about smoking a whole lot. So, as we got our legs underneath our programs, as I mentioned previously, I think the United States is a little different than a lot of other countries who have had harm reduction programs that are really well established nationwide, for decades. We really didn't have that. So for a lot of communities, and I know it's not all, some areas did have had harm reduction programs, but those are more isolated. But for many communities, it was just in the last really 10 or so years that we really started seeing these programs develop, get some funding, be taken in often by health departments, be ran by health departments. We still see a lot of grassroots programs, a lot of underground programs. Those remain the most effective of all harm reduction programs. But we do want to see health departments and hospital systems embrace harm reduction and come into this work. And as that started to happen, just as we kind of got everybody on board, we started to come to the table, some of the more old school harm reductionists, and say, hey, we should be talking about smoking. We should be talking about smoking drugs. We should be talking about safer smoking kits, and maybe even giving away pipes. And you can imagine how that went over at first, but after it settled in and we were able to present the research and really talk about it, people do smoke drugs, and we want people who are smoking drugs to engage with harm reduction programs. We want to give them naloxone. We want them to get that public health messaging. We want to build those relationships, give them resources, and really essentially engage that portion of the population. And with the data that we were receiving on some of the racial disparities and other numbers, we really felt like this was something that we needed to do, that we were missing the mark in this area. So dispensing those has been extremely effective and extremely very popular. And it is our most vended item out of our vending machine, which I'll talk about a little bit more. Vending machines are also a great way to have responsive programs. It's hard sometimes for people to conceptualize that a lot of people who use drugs may have jobs and other commitments and may not be able to come to a syringe service program or a harm reduction program during the hours that we often want to set, which are sometimes kind of like banker's hours. We need to have program offerings that are in the evening and weekends, and also flexible things like vending machines that can be accessible 24/7 and offer people anonymity. When I first started working with the vending machine, I remember someone saying to me, aren't you concerned that you're not going to be able to talk to this person, that they're not going to get that public health messaging, and you're not going to be able to really engage with them face to face? And my response continues to be that, I want to talk to everyone, of course, and connect them with services. But if I am able to provide services to someone who is either unable or unwilling to engage with me, then I want to do that. I want to expand the reach of our programs. Vending machines are extremely popular and have been well established in other countries, such as France, Australia. And of course, mobile units is another way that we have responsive programs where we can offer people services that we take to them, such as primary care, sexually transmitted infection screening, and sometimes treatment, depending on what type of mobile unit you have, and a connection to care. My biggest challenge when I'm doing direct service delivery is connecting people to basic healthcare. It used to be treatment. Treatment used to be my biggest challenge when I did this 10 years ago. But that has improved vastly. We have a lot of beds, we have a lot of opportunities to get people into treatment, a lot of availability. I will say some of it varies, and it's commitment to evidence-based practice and quality. We have to be kind of careful about vetting those partners, but we have seen tremendous expansion. The real challenge is when somebody says to me, hey, I used to take an antidepressant, but I haven't seen a doctor in a while. I was in jail last year and I've been in and out of transitional housing, and I think this is something that I need. And then I kind of set upon the task of trying to connect them to care, and that can be extremely challenging. So having those primary care services can be really great. Wound care is huge. Wound care has always been important with syringe service delivery, often because of the abscesses that are associated with injection drug use. What we've seen in recent years, especially with the emergence of xylazine in the drug supply, is wounds that deteriorate very quickly and are sometimes not associated with injection drug use or the site of injection drug use. So they can be all over the body, and xylazine and the drug xylazine causes soft tissue destruction. It's not intended for human consumption. So we were seeing, and this is in many parts of the United States. I think xylazine has been detected in almost every state. So really seeing those wounds that are severe and progressing very quickly, and how do we manage them? So this is one of my favorite pieces of research evidence that I like to talk about all day, every day, if I get the chance. Concurrently run syringe service programs and wound care clinics are uniquely positioned to facilitate care to people who use drugs. Providing new sterile equipment as well as early wound care intervention can reduce morbidity and mortality, as well as healthcare expenditures, by reducing the number of soft skin and tissue injuries and injection-related wounds that require hospitalization. Establishment of wound care clinics as part of an SSP represents an untapped potential to reduce harm. I love that. This is something that is effective. It's better for the population. They're more likely to engage in the healthcare service that we're offering, and it's also cheaper. It reduces mortality and morbidity and saves healthcare dollars. So even though I say that, oftentimes people are like, "Oh, healthcare is complicated in this country, and we got to do this and we got to do that, and I don't know how we can do it." What we know is that wounds require ongoing treatment, and they will not be healed by a visit to the ER or even a brief hospitalization. So we know that in other aspects of the work we do, and it certainly applies here. So I think the real question for anyone on this call who is running or working in a harm reduction program, we should all be asking ourselves, who are the community-based providers that we are referring our clients to? And too often the answer is the ER. There can be often a misconception that these wounds are so complicated, and I don't know where to begin with that. And there's no way I can do it in this primary care community-based primary care center. They have to go to the emergency room. But we know from other aspects of wound care. Wound care is something we know a whole lot about in the United States. It's a billion-dollar healthcare business, and we know that community-based wound care that can be given on the ongoing basis, where you change what you're doing, you see the wound a couple times a week. It's very dynamic, and that is what is most effective. What we also know is that wound care clinics that are embedded in syringe service programs are highly effective. There was the great study that came out, Wounds on Wheels, out of Baltimore. This has been, oh my gosh, probably 7-8 years ago now. They found that people came back to see them week by week, and I can certainly attest to that. When you do syringe service programming or harm reduction outreach, you see the same people week by week, and you really get to know clients because they are engaging in a health-seeking behavior by just coming to get supplies and services from that whether it's a mobile pop-up or a brick and mortar space. So having additional healthcare there is just a win-win, and people they have better follow-up, and this is what Wounds on Wheels found out of Baltimore, is that the residents and the physicians that partnered with the SSP to provide that wound care with the SSP found that they had better outcomes, The clients were more likely to come back and see them than in other models, such as models that weren't associated with harm reduction outreach. So what we really need is access to low threshold medical care, walk-in appointments, assistance with Medicaid enrollment, and have these embedded in harm reduction service delivery. And I think that cross-sectoral collaboration is really key. We need to have some sort of forum in communities where people can come together from harm reduction organizations, homeless outreach groups, people who are working in food scarcity and housing and hospital systems, emergency rooms, first responders, law enforcement, all important partners to be at the table and just start having those conversations about, hey, I don't think that we need to send all of our clients to the emergency room, and here's why, and how we can have better outcomes and save healthcare dollars if we do so. So overall, this improves healthcare health outcomes. It is a client-centered approach, which is what we all seek to do all the time. We're working the ability to provide a service that meets someone in their own environment on their own terms to offer them the services that we need today is going to be more effective. It saves healthcare dollars. I'll just use my home state of Ohio as an example. An average visit to the ER can be almost $1,500, whereas community-based care can cost about $120. I think this next two bullet points are also really important, and I don't think we really think about it enough sometimes when we're thinking about harm reduction service delivery. These types of services can also divert non-emergent care from the ER. And in many communities, I would maybe say all, the ER has been through a lot. COVID has really took its toll. And, often there's also, a nursing shortage and a provider shortage. And, let's leave the ER for emergencies and let's divert these non-emergent visits to community-based partners. And also societal productivity. We don't often think about how intervention now can really save the societal productivity of an individual later. If I have a client who has a significant wound on their forearm and they lose the use of their hand, or maybe even have to have an amputation, what is the real cost of that for their lifetime? I think that cost is profound and significant. The Australia harm reduction has a metric that they like to talk about. For every dollar that they spend in harm reduction, they can gain $5 in societal productivity of the population. So let's talk a little bit more about vending machines. Talked a little bit about mobile units and how they can help. So vending machines are a great way to have responsive programs, partly because it's a really flexible delivery setup. For example, when we started our vending machine, it was during the height of COVID, and we were able to put PPE in there. And that's not something that maybe we're vending right now, but we could certainly do it again if we needed to. Harm reduction vending machines have been used since the beginning of the HIV/AIDS epidemic in the 80s. They've had long-term, well-established success in Australia, France, and Canada. There are over 200 machines in Paris alone, and these are all very well established. Here in the United States, this particular vending machine is in Nevada. It's from Track B. They started their vending machine in 2017, and they were the first, and for quite a while, the only harm reduction vending machine in the United States. In 2021, we started the second here in Southwest Ohio with my partner, Caracol. And we started the vending machine here, and we have seen tremendous success. And since that, we have seen expansion into other communities. For a while, Caracol, during 2021 to 2022, the first year, Caracol was having monthly webinars where they would support other communities that were looking to learn about the vending machine. So the vending machine is cost effective. It can operate 24/7. It can reach difficult to reach populations, offering anonymity and 24-hour, 7-day-a-week access. It can also increase syringe collection. That's why I use this picture. You see this giant sharps box right here. People who are coming can bring syringes and turn them in. They're not limited in their ability to do that. So our machine is a harm reduction machine, and we have a variety of harm reduction materials. Some machines are Narcan only. Some machines in some parts of the United States have syringes in them. We do not. That is something that we are not currently permitted or haven't been permitted to do since we started in 2021. We do have safer smoking kits, including pipes. Um, so what is in our machine? We have sharps containers, which at one time was our number one most vended item. We have Band-Aids, which are extremely popular. We have treatment and other community resources, disease prevention and education. We have safer sex kits, safer smoking kits. We have safer injection kits. They do not have syringes in them. They just have some of the other aspects, the cottons, the cookers, those sorts of things. Fentanyl test strips, naloxone, pregnancy tests, and also PPE kits. Pregnancy tests are a frequently vended item. Once we saw the popularity of it, we have continued to support and look for ways to find funding and to kind of keep that going. I think that's another example of how the machines can divert visits from the ER. I think if we had a couple of ER nurses on this call, they could probably attest to a certain level of people who might show up at the ER really because they need a pregnancy test. Who is using the machine? This slide is I think I edited it and it didn't take. I must not have saved it. But the numbers are much larger than 800. This is from an older presentation, but it started in 2021. We are engaging stimulant users and people who smoke their drugs, which is a group of people that we were not currently engaging with when we were doing just a syringe service program. Over 15% of the people who come and use the machine for the first time tell us that this is their first time accessing harm reduction services. So what that tells me is that this is a client who wants to access these materials in this way. They haven't engaged in other harm reduction outreach. This is the outreach that works for them. And that can be for a variety of reasons. Maybe they like the privacy. Maybe they work a lot and they can't come when programs are open. There can be a variety of reasons. So our most vended item, safer smoking kit is our number one most vended item. In our machine, we have two types of smoking kits. One has a pipe that's called a stem, and the other one has a pipe that's called a bubbler. And again, that's an example of being responsive to the population we serve. We had focus groups and spent time with people who use our services and in the harm reduction community and people who use drugs so that we could know what kind of pipes do we need to have, what are people using, what are people gonna come to our services to get. Safer injection kits, Band-Aids. The fourth one there is also a safer smoking kit, but with the other type of pipe. PPE, sharps container, Narcan, we have nasal or IM naloxone, and then a pregnancy test is on the list of one of our most vended items. So in the context of both the vending machine and the mobile units, how do we do these things? I think community and academic partnerships can be a great way to offer these types of services because many programs don't have any sustainable funding. I talked at the beginning of this presentation about the significant expansion of harm reduction programs that we've seen in the last 10 years. But the reality is that a lot of that money is not long-term sustainable funding. Many programs are not part of anybody's real perm budget. So I think that those academic partnerships, and me and Caracol is an example of that. Caracol is the largest HIV service organization in Southwest Ohio, and I have been in partnership with them for the last 10 years. We met through doing syringe service program, the very first one that we ever had in Cincinnati. I showed up as a volunteer, and Caracol staff was behind the counter, and we just hit it off, and it was a marriage made in heaven, and we have stayed together all this time. I did my DNP project there on evidence-based models for syringe distribution, and we've just continued to adapt to what's needed. At the end of 2018, the health department in our community took over the syringe program that we were running, which was great. You know, they had more money and could offer more infrastructure. And so then we kind of continued to pivot to see where the need was. Doing the vending machine in 2021, launching wound care, having me out on the van with Caracol, being able to do wound assessment out in the community and to be able to offer people resource referrals. And we're continuing to do that. Now we are providing that wound assessment in their brick and mortar clinic space 1 day a week. I'm there and I'm able to connect people with care, sometimes help people understand discharge orders that they have, or maybe get into my chart or understand Medicaid enrollment, all of those types of support services. And that's all really through an academic community partnership, because I'm not an employee. I'm not there getting paid. They probably don't have the infrastructure, I shouldn't say probably, I know they don't, to have an RN on staff, a DNP prepared RN, but because of this partnership and the type of position I have at my university, I'm able to be out in the community doing outreach 1 day a week, and for me, that 1 day a week is with Caracol. And that allows us to really bring care to people who need it, which is something that academics want to do too. We need to maintain our public health practice, and we want to, keep our hand in that work, because that's why we got into this. I love teaching, and I also love practice. So it's something that's good for both parties and definitely benefits the population we serve. Interdisciplinary teams such as nursing, social work, pharmacy, medicine. Pharmacy, in my example with the vending machine, the University of Cincinnati School of Pharmacy was a very important partner in the vending machine and helped facilitate data collection and data analysis associated with the machine. And also making that investment in community-based harm reduction strategies, continuing to advocate for a continued investment, that these programs are working and they need to be sustained. So future work, syringe service programs need to have the flexibility to respond to the needs of participants. They need to be more innovative with minimal barriers, and to really explore how to reach diverse populations. For example, we didn't really talk about it today, but another responsive way to meet populations is with backpack outreach, where people are going out into the community and providing services directly to people in their own environment. That's something that's been very well established. Portugal, for example, has a really great model where they have, social workers and nurses. They go out into the community together. But really kind of, expanding our perspective on what harm reduction programs are. They're more than syringe distribution and collection. And if we're really going to, wrap our arms around the community of people who use drugs and provide them with the services that they need, we need to be thinking beyond the syringe distribution. Participant involvement is key to any kind of program development. Increase in harm reduction knowledge among community decision makers, health professionals, policymakers, law enforcement. I think that it's a long game, but it's so worth it. Nobody's gonna solve this by themselves or make any progress in fighting infectious disease and the deadly epidemic of drug adulteration alone. We need everybody at the table from a variety of different sectors. And harm reduction vending machines really can be an integral part of a multifaceted approach to substance use in the community. They're flexible, they're adaptable, and popular. I mean, the people who have started machines, there have been many more. I mentioned Nevada was first. We were second, but there have been many. South Dakota has one, Idaho, lots and lots of people here in my state, multiple counties have them now. One of the fire departments has one that just has naloxone in it. I think some emergency rooms have them with naloxone available. So just really, thinking about how to be more innovative about that outreach. And I think it's important, to have low threshold interventions because that's what's going to be effective. I could when I do when I want to go out and reach the population that I serve, maybe the best time for me to go is after I drop my kids off at school at 8:30 in the morning. But that's not the best time for the population I serve, right? So that's not when I do it. So just continuing to think about what's really going to work. And leveraging vending machines can also not just help with syringe distribution when used appropriately, but also with syringe collection. And I also just want to say, kind of in closing, that I've been contacted by a number of press outlets in the last, few months to talk about what do we think in the harm reduction community about, decreasing overdose deaths in the United States, such a significant increase. I think that the real takeaway for me is that this is showing us that harm reduction works. We were not a country that was really we weren't really implementing a lot of best practice harm reduction programs before 10 years ago. And we all know that in public health, it takes time to see the fruit of your labor, to see the benefit of, to see the numbers move a little bit. And I think we are finally seeing a little bit of a glimmer that these programs are effective and we need to keep doing it. This isn't a time to de-invest in this kind of work. And then most importantly, to continue to remember that yes, we're seeing a decrease in those numbers, but not in communities of color. In particularly, Black communities and Native American communities are seeing in some areas a significant increase. So that tells us that we have a lot more work to do. And then these are my references, and I think I might be ending maybe right on time.
Yeah, it was perfect. Thank you so much. All right, so if you have any questions, please use the Q&A section just so I don't miss it in the chat. I will start with I have the first two questions in the chat, so I do see those. And I think it was about the vending machines. There was two questions. Is there a charge to any of these products in the vending machines? And then are there problems with children accessing them?
Oh, that is such a great question. All of the products are free, and we do have a system in place because since they're all free, there have been communities that have launched a machine like this and it was empty in hours. And they were kind of like, oh, shoot, like the machine has completely been emptied out in the first couple hours. We have a system, so people either in person through outreach with us at Caracol, through one of the outreach workers at Caracol or a harm reduction worker, they are enrolled to use the machine and they're given a number, an anonymous number. And then they can access that machine at any time. And each item can be vended for free one time in 7 days. So I could register today, I could go to the machine and I could get every single thing out. And then I could do it again, but not until 7 days later. And that's like down to the minute. So we always kind of explain that to our clients. Like you could take out everything, but you won't be able to get it again for 7 days. And that seems to be working pretty well. If somebody needs more safer smoking supplies, if they need more condoms, they can always let us know. We encourage them to contact us sooner than that 7 days, and we can meet up with them through outreach and provide them with more supplies. And then the question about children, it has not been an issue. It is something that some of the community decision makers were concerned about. And so we do, if we had a minor that wanted, in general, if we were to engage with a minor, it's not something that happens very often, but we have some social workers that have some resources and things that they do in that nature. But you do need to be 18 to use the machine.
Great. So if somebody sees the machine on the street, how are they able to get in contact with the team to get it?
There's a phone number on it and they can call, and that number is answered 24/7.
And then we have a comment slash question. It says, please excuse, I do not have much exposure to harm reduction programs, but could harm reduction programs enable drug use?
Yeah, I appreciate you putting that in because I think a lot of people can sometimes feel that way, but research shows that they do not. I think the thing that I always think about to myself is if making things hard on people and taking away their liberty and their housing and their children and even putting them in jail, if that deterred drug use, United States would be leading the world in our response to substance use because we lock up more people than anybody else on the planet. And what we know is that it doesn't seem to deter drug use. Offering people services does not encourage substance use. There's been no research evidence in the last 40 years to suggest that.
Great. Okay, so this question is topical to now, so I'm not sure if you do have an answer, but it said the HHS is cutting federal funds to a lot of substance abuse programs countrywide. Do you anticipate negative impacts to your harm reduction program?
I think that it's a tough time in public health all around, and I think most of us are concerned. I haven't met anybody in public health recently who isn't concerned. I try to remind myself that this administration previously maintained their commitment to harm reduction and to naloxone distribution. But I would be very concerned about those cuts. And I think, like all members of the public health community, I am very concerned about the cuts that we're already seeing in some other areas.
Great. Okay, so another question we have is how do you vet partners who will provide care to clients that is consistent with the harm reduction principles?
Yeah, so I think that if you are someone who's running a harm reduction program and you want to, do some innovative things and you want to expand the services that you're currently providing, I think it's important to go out and vet partners and meet them. So for example, I talked a little bit about needing to um, I'm sorry, I was just having a pop up there on my screen, talked about needing to connect my clients to primary care. So I did have an instance once where I was gonna, I had a primary care provider who had said they were willing to see our clients, but then when the client went there, they didn't want to provide services that they needed. They didn't want to do wound care, for example. So that was kind of a wake up call for us where we were like, we really need to go out, visit them in their office, talk with them about who our clients are and what their needs are, and be sure that they're open, because I think that there's a lot of stigma that's still out there. I think for a lot of us that work in this space, we don't think that way and we don't really encounter a lot of other people who do, but I think there's still a lot of stigma out there. For example, I sometimes consult and volunteer with other programs and in other states, and I recently was asked about a situation where we were doing an SSP right in front of a clinic, and that clinic did not want to see those clients. Their messaging was they need to go to the ER because they have needs that we can't meet. So I think that's a significant misconception. And I think the best way for us to work on that is to continue to meet with community decision makers, leadership from clinics and public health programs, and really try to lead with the research evidence that these people deserve the same kind of health care that anybody else would.
Great. All right, next question. What do you think about the decreasing overdose deaths in the United States?
I think that, of course, it is great news, and I think it's evidence that harm reduction works. I am very concerned about the racial disparities in those numbers.
And then how do public health programs keep up to date with drug trends in their regions?
I think the best way, some of the best ways to do that is with any type of coalition that you can become a part of, whether you're a primary care provider or you're working in the emergency room or you're based in a research center or an academic, looking for those community-wide collaborative coalitions that get people together from a variety of sectors. Oftentimes in those meetings, they will present drug seizure data, data from the coroner about overdose deaths, and that really helps inform us to know, for example, is if when xylazine was found in the drug supply, or nitazines, or whatever it might be. And we have had a lot of progress with programs putting out like warnings about overdose deaths. That's something that we weren't really doing in my region 10 years ago, but now we'll see flyers out on tables or emails to clinics and healthcare providers that say, overdose alert. We had a number of overdoses between these dates in the emergency room. This is what we're seeing. Everybody be aware. And then offering some resources to people, about not using alone, doing a test dose, testing your drugs with fentanyl test strips, et cetera. So I think that all of those things can really help.
And then we have a question again about the vending machines.
Sure.
But how do you determine where to install them?
Oh, I think that there's a lot of things you can consider. For the one that I was a partner on and I'm still a partner on with Caracol, it was kind of a great, our location was a great location. People come there for syringe service programs once a week. That's ran by the county health department. And then they also have HIV and Hep C testing, and we all have other services that are available there in that brick and mortar space. So we really thought a lot about where we should put it, and we landed on a space that was covered from the elements, well lit, but also lended itself to some privacy.
Yeah. Great. A question about funding. So how do you fund these types of programs to make sure they're sustainable?
Well, sustainable funding is a consistent challenge for all of us. It's always on our mind, and we don't have any. I will just tell you that right now, that that there's not a lot of sustainable money in harm reduction service delivery in the United States. But we work hard to be good stewards of any money that we're given and to show evidence to partners that our programs are working. We do a lot of presentations, we collect a lot of data, we apply for a lot of grants, and for the most part, it's patchwork. It's patchwork money from small, like we have an organization called Interact for Health. It's just an independent private organization here in our county, and they were the first people who gave us pretty much the startup money for the vending machine. And there's a couple of other examples. Right now, I have a small organization called 513 Fund that is giving me a small grant of $40,000 to increase outreach to medically underserved people who are at risk for HIV. And we're doing some of our expanding some of the things we do with those funds.
All right, we just got a flurry of new questions. So I hope you're ready.
Okay, I'll do my best.
Yeah, the next one. Could you talk a bit more about the space where law enforcement and harm reduction intersect, in
Oh, yeah.
particularly with these machines? What does it look like when collaborating?
Well, I think you really have to have the buy-in of law enforcement, in my opinion, to be cleared to have a machine. I think if law enforcement in your community was really against it, then you would really struggle to get the health commissioner or the city council or whoever it is that you need permission from. You're not really going to get that without buy-in from the police. Law enforcement are really important partners in harm reduction. I think that when I very first started this work, they were often the people at the table who would say, I can tell you one thing, whatever we're doing, it ain't working. So we have had, and sometimes that of course, you're going to encounter barriers. There's still certain communities that don't think that harm reduction is appropriate and don't think it's something that they want in their community. But for us, having buy-in from law enforcement is important. And what it looks like really is getting that program approval, being approved to operate.
Yeah. So somebody said they've seen billboards that say fentanyl kills, sponsored by their county to health departments and police departments. Do you think that this is an effective harm reduction tactic?
On one hand, they're not wrong. I mean, fentanyl is deadly. I wonder sometimes when I see some messaging like that, if there was a lot of collaboration with public health professionals that could really kind of help with the messaging. But I think one of the billboards in my region that I think is great that I saw recently is somebody had pressed pill in their hand, and it was something to the effect of, did you know fentanyl can be in this? And so I think that messaging that lets people know, I'll share a somewhat personal story in my extended family. So not my close family, but kind of extended family. There was an overdose death a few years ago. And one of my sisters said to me, I didn't know they were on drugs like that. And she wasn't trying to say something stigmatizing, and I really understood immediately what she meant. What she meant was, I didn't think they shot up drugs, or I didn't think they did heroin. And so I said to her, well, I think they did a lot of pills. And I think that, fentanyl is in a lot of pressed pills that are on the street right now. And that's why we're seeing this. So I think that messaging that kind of lets people know that fentanyl might be somewhere that you're not expecting it is important, because from a public health perspective, our job is to kind of educate the public on what their risk is, so that they can take steps to protect themselves.
Great. All right, this will be my last question. So this one is, are there any services provided via the vending machines that are particularly popular or successful?
Services through the vending machines that are popular and successful. Safer smoking kits has been our biggest success out of the machine. Being able to engage the community of stimulant users is something that our programs were previously not doing because we were just using syringes.
And then last thing that I just want to say is, because we've had a lot of wonderful questions, if anyone would like to get in contact with you to just discuss, brainstorm, hear about yours, what would the best way to be get in contact with you?
Oh yeah, you can find me. I have a profile on LinkedIn. I'm also, if you just Google my name, University of Cincinnati, my email will come up, and my, all my info from UC, and you are welcome to contact me.
Great. Well, thank you so much for that very informative presentation. I will put up the video, everyone, this afternoon, so it should be there tomorrow, and I'll send out the link to that if you would like to watch it again. Thank you especially to Dr. Turner-Bicknell. I really appreciate you taking the time to present today, and I hope to see everyone next month at our next session. Thank you.
Absolutely. Thanks for having me.